you see? Terry? Oh, it's here. Okay.
Set the example and silence my phone. So, good morning. It is still morning a little bit here in Central Time Zone in Tennessee. I realize there's some on the line. I will say good afternoon to you, and you might be in other places throughout this world. This is an exciting time. Welcome everybody to Murray Regional Medical Center and what I'm going to call our first annual Innovation Seminar. So we're setting something here that hopefully we'll be able to continue in the future. So a couple of weeks ago, our Board of Trustees and our leadership team officially approved new, what we call strategic anchors for our organization. Now we view our strategic anchors a little bit different. We don't view them, and I'll give Deborah Lumpkins, our Chief Nursing Officer and Chief Operating Officer, the credit for coming up with this idea, but anchors for us are not like boat anchors, where they're holding us back or holding us down. We are viewing our strategic anchors like what a mountain climber would use, which are the anchors that you hammer into the rock above you, that you then can pull yourself up on as you climb a mountain. So that's how we view our strategic anchors. And so the anchors that our Board of Trustees have identified for us moving forward are quality patient care. How can we remove variations in the care that we provide that lead to different outcomes? Highly effective teams is an anchor, which involves creating an environment where everybody's talents are respected. Everybody on the team brings something of value. Stewardship of resources, making data-based decisions, that's challenging for organizations. As you think about plotting your course in the future, how can we better use data to determine our course? And then the last one is innovative culture. Adopting solutions that improve efficiencies, reduce errors, reduce waste, reduce redundancies. And I like this definition of innovation. And that's the ability to see change as an opportunity and not as a threat. So that's an important anchor for us as an organization. It's been interesting to me to see my own son's journey through medical school over the past few years. So one of my sons is done with medical school, he's in his fellowship, the other is between his second and third year, just started his third year of medical school in the University of Tennessee. So I compare what they're learning and how they're practicing medicine with what I was taught 30 years ago. And it's very different. Technology, day one of medical school for my youngest son, when you go to gross anatomy lab and you're there and you start on the cadaver, day one for him also involved an ultrasound lab in which he was learning through what is artificial intelligence using sound waves that reconstruct images that you can peer into the human body, correlating that with what he's learning in gross anatomy. It is said that the average medical student today learns about 60,000 new words in 4 years. That's like a new foreign language in 4 years. Most foreign languages have about 60 to 80,000 words in their vocabulary. So medical students are learning this, and the rate at which technology is changing, new discoveries, new concepts, as data comes together and creates, more knowledge, that it's mind-boggling at the pace that this is increasing. So we need help. I was at a conference earlier this year, and there was a speaker named Nathan Kaufman, who's a consultant in healthcare, and he made this statement that stuck with me. And he said, artificial intelligence, or AI, is not going to replace doctors and nurses, but doctors and nurses that use AI are going to replace those that do not. And I think we see that every day in the evolution of healthcare. I've been asked to introduce Dr. Amit Chokshi to you. I think that's a challenging calling to do so. Those that are in Murray County, they know Dr. Chokshi. He has practiced on our medical staff since 1987, 37 years now, and I would say he's influenced the healthcare in this community almost as much as any other single physician has done so in the past. Dr. Chokshi's passionate about a lot of things, and if you know him, you know that that's true. But there's one thing in particular that his passion centers around, and that's the physician-patient relationship. That's very important to him. That sacred relationship, which is at the core of all we do in medicine, creates that genuine trust between a patient and their provider as they chart that patient's health journey. And part of that comes calling as an advocate. An advocate is another one of our corporate values. Dr. Chokshi is an incredible advocate for his patients, and he does that by making himself available. He gives his cell phone number out to patients. They can call him when they need him. And I appreciate his friendship through the years, his mentorship of me, and my support for my leadership journey, and very honored to introduce him to you right now. So thanks, Dr. Chokshi.
I'm honored to be here today in front of an esteemed audience, and it is an honor to have amongst us Mr. Girish Krishnamurthy, who is the CEO and Managing Director of Tata Health. Tata is a household name in India and is getting to be that way outside of India. It's the largest business conglomerate, and most people in America would know Tata by the cars they make. I know Ms. Lumpkins and I know Mr. Stuart Parker, they like Range Rovers, which is a Tata product. It so happened once I was flying from Bombay to New York, and there was this very quiet gentleman sitting next to me. On my left-hand side, on my right-hand side was the rest of my family. And after the plane took off, the pilot, the stewardess would come and ask him, "Sir, you need anything?" And he would just smile and say, "No, everything is fine." After a while, when we were about 10,000 feet above the sea level, I said, "You must be somebody very special," everybody's asking. He said, No. I said, "What do you do for a living?" "Oh, I just manage some companies." And then I asked him about his hobbies. "Oh, what do you do?" He said, "Oh, I like to run." He didn't tell me that he had run every marathon in the world. So then, as we were disembarking, he had advised me to read a book called Bridgital Nation, which I have bought a few copies, but I forgot to bring it here today, but I will give to whoever is interested. Bridgital is a new word coined by them because it bridges using digital technology. It bridges the urban and the rural India. It bridges the haves from the have-nots. And it is a dream of the chairman of the company, Mr. Natarajan Chandrasekharan, who has been given highest awards in France, in India, in Holland, civilian awards. So it is his dream that he can provide the best of healthcare in the remotest part of the India where otherwise it is impossible. So in order to bring his dream to fruition, he found one man and he assigned his dream to him. He said, you take this dream and run with it, and I'll back you up. That man is Mr. Demystifying AI. So I visited one of his pilot projects in a remote area where he's serving 3 million people where there was no healthcare before. And I interviewed several patients, some directly, some through interpreters, and they all said they're God sent to us. And so we have amongst us a very accomplished gentleman who is an engineer by education, but he's a thinker. He thinks about tomorrow, and he's a doer. So he brings tomorrow into today. So he has launched healthcare initiatives in rural India as well as in urban India, where he has developed an AI platform driven by generative AI and LLM or large language models to focus on clinical workflow optimization, patient outcome improvement, and drive the efficiency across the healthcare continuum. And this has already been tried. Before he comes to speak to us, he has already implemented and shown that it is very effective in over 5 million people and counting. So we are just very blessed and fortunate that he agreed to come and address us. He also is going to address another group of people in Franklin later on, and then in New York. So we are very blessed that he agreed to come here. And in bringing him here, I must also thank several people. The list is long, but I hope I don't miss a few. Because starting with Dr. Cheney, he immediately agreed to organize this. Ms. Rita Thompson, she's the communication director. She helped set up the IT and the cuisine. Ms. Jennifer Bassam, any problem I go to her and it is solved. Mr. Greg Whitlock, our head of IT, I disturbed him on a Sunday while he was driving to Kentucky. I apologize. Mr. Stuart Parker, he's my backbone. He said, what's the problem? Don't sulk. I said, this IT, I'll take care of it. So, Stuart has been a great help. I also want to recognize two very important people here. Mr. Bill Walter, my first administrator. I'm here because of him. I owe you my career here. And Mr. Dr. Tom Dake, who was an avid supporter all through the beginning of my career and throughout. I also would like to thank Mayor Sheila Butt, Mayor Chaz Moser, who has agreed to come here, and of course I cannot forget Ms. Beverly Horner, the chairman of our board. So I thank all of you for making this possible, and I'm going to now ask Mayor Sheila Butt and Mayor Chaz Moser to come and honor our guest.
Dr. Chokshi, for the invitation to be here. Let the record reflect when Dr. Chokshi extends an invite, I show up. Dr. Cheney mentioned how beloved Dr. Chokshi is, and it is true. I would say actually, perhaps Mayor Butt, you'll agree with me, he may be the actual mayor around here. Speaking of mayors, you actually have two mayors in your presence today, myself along with Mayor Butt, and on her behalf as well, I extend a heartfelt welcome to Columbia and Maury County, Tennessee, to all of our visitors here today. Dr. Cheney, I appreciated your opening remarks, and I couldn't help but think of every time I have the opportunity to speak about Columbia to a crowd, whether it be a local crowd or a crowd that has some folks from across the world, which we have here today. I always talk about many attributes and assets that we have as a community. Being the home to the Tennessee Farm Bureau headquarters for the state of Tennessee is certainly one of them. Being the home to the state's first community college in the state of Tennessee, Columbia State Community College, is one of them. Being the presidential site of James K. Polk, former president of the United States, is something that we're proud of. But I'll always include in the conversation the fact that we are the home and the site of Maury Regional Health System. It is a world-renowned system that is saving lives and changing lives on a daily basis. It's a health system where my 3 children were born, where I have the opportunity to just today communicate with my doctor over an issue, and I'm very grateful for the services that this system provides, not only in the medical care, but also in having these kind of programs that is providing an opportunity for business and medical communities to get together to learn more about very important issues. And so, Dr. Cheney, I say thank you to you for your leadership and for Maury Regional Health System overall. I do have a proclamation, and this is going to be a Mayor Butt and Mulder proclamation, and I will read it for you. I got the opportunity to speak with Dr. Krishnamurthy earlier and get to meet him. He gave me permission to refer to him as Dr. K, not to be confused with Dr. J, but I'm going to do my best to pronounce his name. But I do want to go through this proclamation, and I think it provides a little bit of an overview and introduction to him and our esteemed guest here today. Dr. Krishnamurthy is visiting the United States, and thanks to a chance encounter that Dr. Chokshi had, Dr. Chokshi, a renowned and longtime medical doctor at Maury Regional, Dr. Krishnamurthy now chooses to visit Columbia, Tennessee during his most recent trip and visit to the United States, where he is being welcomed by and sharing his time and experiences with Columbia and Maury County's medical and business community. And whereas Dr. Krishnamurthy is the managing director and CEO at Tata MD, a pioneering healthcare provider, which under his leadership has been a trailblazer for a unique healthcare model for chronic diseases in urban India. Dr. Krishnamurthy's other work at Tata in leveraging innovations of AI and large language models to positively change the healthcare landscape as it relates to patient-doctor interactions has also been innovative. Dr. Krishnamurthy has used his transformative thinking to conceptualize and execute new and progressive solutions to complex problems in the areas of healthcare, medical and diagnostics, and skill development. He has lent his entrepreneurial experience across other key sectors as well, such as software products, retail, IT services, skill development, manufacturing, and other. The City of Columbia and Maury County is honored to have individuals of such high esteem and respect, and indeed pioneers such as Dr. Krishnamurthy, to visit our community, and it is appropriate to recognize those individuals for their good work and for spending time here with our local community members. Now therefore, I, Chaz Mulder, along with Mayor Sheila Butt, mayors of Columbia and Maury County, do hereby proclaim Wednesday, May 8th, 2024, as Dr. Krishnamurthy Day in Columbia and Maury County, Tennessee, and urge all of our citizens to pay special tribute to this extraordinary person. Congratulations.
Thank you.
But you would like to come up so we can present? Josie? Let's see. Here we go. I'm going to let you stand right here.
From here, this side? Yeah, okay.
Here we go.
Come. She's asking us to come in the
Two
front.
steps forward. Oh, there we go.
Thank you. Thank you. Thank you.
I'm sorry I omitted a couple of other people. Dr. C.W. Ball is here. Believe it or not, he was in a ponytail when I first saw him. Things have changed. Dr. Kennedy, they have also helped me build my practice and helped me through my good times and bad times. So I thank all of you. And now I ask Mr. Suzuki to address.
Good morning. So first of all, it's a great honor to be here in front of all of you this morning. And I want to thank Dr. Amit Chokshi for inviting me on behalf of my organization I represent. And also I thank mayors, both the mayors, for doing the proclamation this morning. It's a great honor, and also for the first time I've been addressed as a doctor, so I'll take it that way. And so, given this topic to me this morning, I was just thinking, before the meeting I met most of you and got introduced. So we have a varied background of people. We have people with very deep medical experience. We have people, the administrative experience, and we have people, technology experience, and then I have few AI experts also part of the audience. So I will try to calibrate myself how we can approach this morning. So I initially do an introductory remark about taking technology AI out, what we have done, and how it has impacted the overall healthcare. I think that is the whole purpose of everything. So I will share our experience and experiments in this journey. As Dr. Amit Chokshi told, it's a vision of our chairman, and healthcare is the most important aspect of human community, and we need to be working on it. And the technology and the world, the way it is shaping up, it has to necessarily shape up healthcare too. So in that overall thought process and a vision, I've been assigned with this task of experimenting and creating impact in healthcare. So without any further delay, I will get into this on our experience of healthcare. So the transformation journey we started in this aspect of Bridgital world in the year 2015. And we had a deeper experience in a multi-specialty hospital like yours and handling large volume of patients. This is one of the largest hospitals. It is the largest hospital in Asia. Further to that, we entered into the same thing model into a cancer care, where in a super specialty cancer care, how this model and concept can be experimented. We could serve close to about 1.8 million cancer patients and learn from that. Then we thought it is necessary on the primary care and secondary care setup, and it is necessary in the rural India. And then finally, we also realized the biggest aspect of our mankind currently is affected by the chronic diseases, and which is predominantly in the urban part of the world. So the holistic thought process of the same concept implemented in multiple places and created an impact close to about 5 million citizens or 5 million people. And I would like to share that first and where our current focus today. And then we can quickly interact ourselves, or we can take that as a more of an interaction session, how the AI is going to play a role on this. With your permission, I'll go through this quickly. So our journey began in 2015, and we have done, as I said, multi-specialty hospital settings, super specialty care settings, like a cancer care, and also primary and secondary care in rural and urban setting, which is kind of gives a holistic idea of what we are capable of. So this is one of the largest hospitals in Asia. And given the population of India, it attracts about 10,000 new patients every day morning. Their OPD is about 10,000 every day. It's like a mind-boggling count. And the problem there is sometimes it used to take days to get into OPD to see a doctor for 2 minutes. And people queue up at the morning 4 a.m. If they are lucky, by end of the day, they will get through it. Otherwise, it is next day. The queue resets every day. And it looks like more like an immigration problem, but it's a healthcare problem. And so we have been charted out to see how technology, digital technology, can solve this problem. It took about 6 months to solve the problem, but we solved it. We solved it in such a way, it's an unmanageable patient count, and how the health system don't know how to get people in aligned manner. How do we get people, because most of the people comes to your hospital unannounced. And it's overwhelming, and then you don't know what to do with them because there are two unknowns are meeting at the same time. So that is where we applied technology. It's the first time. In fact, I spent about 5 consecutive days in Disneyland and watching how they're managing crowd. And then picked up and visited several places where they're lodging crowd and brought it to healthcare. And we solved this problem with 3 things. This is the first time the healthcare processes was defined by a non-medical professionals and came up with the various management process in place. We brought in technology. We saw through every process through technology, not through the actual healthcare outcome or healthcare delivery. So it was a different experience. Then, for the first time, we added a new job definition and a new skill. And we brought in a new concept called patient care coordinators. And given the centered theorem of the idea of a patient care, it brought in a significant result. This particular initiative got the award from the highest award from the Prime Minister of India as the best Digital India project. And annualized basis, we create an impact of about 3.3 million patients. More than 97% are coming for the care, not anymore unannounced. And more than 95% of the people are able to feel the impact. So this is what technology can do. And with this confidence, we moved into a next important phase of this journey. We call it Digital Nerve Center. It's a concept, at the same time it's a technology and a method. We bring in healthcare close to the patient. The first Digital Nerve Center we created for a cancer care in 21st May 2017, where we connected 4 large hospitals of India. One of the hospitals gets about 225,000 cancer patients in a year. This large cancer hospital, we put them together, 4 different hospitals. We put together, we connected all their IT systems, but created a new process of creating care. In a centralized place, we have doctors, nurses, coordinators together, and every patient, they go through this Digital Nerve Center. And the patient care, the continuous care, or before you go to the hospital, what do you do? When you are there in the hospital, what do you do? When you are out of the hospital, what do you do? All those activities, both clinical, administrative. The reason is, when we did this, we did a quick analysis, a project of about 1,800 oncologists we followed. We found 52% of oncologist time spent in non-clinical activity. About 35% of the time is spent on administrative activity. We took that efficiency and brought this technology around it and delivered care for about 1.8 million people through this model called Digital Nerve Center. And this is, as Dr. Amit Chokshi mentioned, this brought in the overall Bridgital model together. This is a very important step when we go into the AI world. So this particular project brought in to bring in 5 principles in a way we wanted to treat patients. A continuous, proactive care, which should be close to patient. And it should be connected and patient-centric. In the United States, we are familiar with that. The most of the services we plan, which is payer-driven and provider-centric, because that becomes the model on which the whole medical process we develop. Now, these fundamental principles become part of our any thinking we are in healthcare. So this is the impact. if you look at cancer care, it's like India, like we have about one doctor for every 100 patients in the United States. It's about 1,600 for one doctor in India. That is a theoretical number. That is true in an urban India. If you take that to a rural India, it increases by 10 times. Then if you take into the top 36 specializations, then it goes into multifold. Just to tell you, in the mental health, we have one doctor for every 700,000 people. It's a huge number. And so given this gap, disease burden, and the kind of availability of infrastructure, human resources, and medical professionals, this model really brought in a huge impact in these areas. Every process of cancer care was taught through a virtual model. Virtual care services, and also one of the important things what we noticed, which is true in every specialization, it is important in oncology. 3 to 4 years of patient record is very important. And in a consultation setting, how to bring those data for a doctor to view it within 2 to 3 minutes. So we developed a patented technology called clinicograph, which allows physicians to see this in 2-3 minutes, just before the consultation, or while driving in the car, or before looking at the list, just looking at it in his tablet, and then look at for 2-3 minutes so that you get the whole idea of the patient. We made chemotherapy, we tested it virtually. We did various different things on the virtual model and impacted close to about 1.8 million people. And very importantly, we also created a tremendous efficiency in surgery. And also one of the important things what we noticed, any cancer patient who hypothetically come in the second stage, by the time you do the overall treatment plan and deliver the care, sometimes the patient end up in the stage 4. So the quick care is very important. Quality of care, at the same time, do it in a timely manner. Speed with the purpose is very important. So we developed a very interesting method of doing virtual tumor board, having a director of oncology doctor across the country together, and very quickly to deliver, and also do a resource optimization. For this patient, the surgery is important within next 1 week, which is the best hospital we can send it rather than do it in your own hospital. So this kind of model really created a huge impact in cancer. As I told you, these are the number of impact. Like we could see in the surgery alone, about 2.6 times we could improve the efficiency. That means you can see so many more patients. So with this, parallelly, we also attempted to do how do we bring in this concept in primary and secondary care. And this is the kind of challenge which you face in the primary and secondary care in India. It is extremely deeper in the rural India. The access to the care is minimal. And you have the primary health centers not equipped with the sufficient doctors or not even available doctors. At a county level or a district level, there are challenges in terms of quality of care. So we brought in this technology and connected about 600 facilities for 20 million citizens, and ability to do patient-wide. Every citizen is registered in a digital platform, and if anybody requires any healthcare needs, they just need to reach out only one digital nerve center. You can go through email, you can through text messaging, you can through WhatsApp, you can make calls. The whole care is owned by digital nerve center, and drive the care for this, direct them to the right primary health center. The doctors are ensure that they are available, and most of the virtual telemedicine is implemented accordingly. The data is available. Before a patient could go, the pre-consultation notes is prepared. So everything is very well planned and executed with about 600 facilities. It created a huge impact, and this became the model. Last 6 years, this is the best district of 20 million people, 2 million people care in last 6 years. Every year, this particular district gets the award. So from there, we moved. So we did all these experiments over a period of 5-6 years and said, okay, now how do we make it real in terms of various different settings? So we looked into 2 focus areas. One is on the chronic care management, and we identified about 52 chronic diseases. And also we also looked at the same model, how it can work on purely primary care. It is extremely driven by technology and AI. So the chronic care management, just to bring in context in the United States level, it is not the problem, it is a problem everywhere. And if you can imagine, about 6 adults in the US are 60% of the disease burden into chronic. Out of that, 2/3 of them have got more than 2 chronic diseases. And this is the one which is going to create a huge bottleneck for the future health system. And if you're looking at the hospital, the way we are managing, it's going to have the more and more complicated as every year pass by. And if you don't, on the current Medicare, Medicaid, the payer-driven systems, the model, it's all based on the current thinking. The future is extremely complicated because the chronic diseases, we are keeping it away from the hospital. But most of the load which is coming into the hospital is because of chronic diseases. And as the people are aging, this is going to become extremely complicated. So we made an attempt to do how to solve the chronic diseases. And this is true all over the world. The current health system is episodic in nature. It is highly disjointed, very reactive, and it is provider-centric and far from patient. And if you take this particular chart, this slide, you go anywhere in the world and play it, everybody will say yes. And that is the scenario. So what is the medicine for this? It's exactly the opposite. We need to have a continuous care, connected care, proactive care, close to patient, not only by distance, but also dearness. Not only nearness, it should be dearness, and it should be patient-centric. So how do we do that? So what we did a couple of years before, we took about 30,000 patients' information for last 10 years. We put together about 100 clinicians together and looked at various chronic diseases and what happens to each patient, and we developed a new model called new protocol and a care pathways, and we call them planogram. So we developed a master care planogram initially for 6 diseases, chronic diseases, which is diabetic, hypertension, thyroid, PCOS, PCODs, allergies. Now we have almost crossed about 20 chronic diseases, but we can do up to 52 chronic diseases. So what it means is, it has the whole, what can happen to a patient who has got a chronic disease. Let's say a diabetic patient. Is he going to be end up in retinopathy or a neuropathy, or what is going to happen? And if that is going to happen, how are we going to be prepared for it? And how are we going to proactively address it so that it doesn't turn into retinopathy very early? How is it going to affect it? So this model has a lot of AI data behind it. That data gives you an idea that, okay, what is going to happen to this patient? So when a patient comes in, we do a detailed assessment and come up with a personalized plan, and which we call as personalized care planogram. Any patient comes in, we look at about 1.5 years view, and then what can be done for next 90 days. For the next 90 days, it is a coordinated care. And it is not just a patient is coming to the hospital or a clinic or a health center. It is the patient and the team together ensuring that the plan is executed. Also in the chronic diseases, the most important part is you present symptoms dynamically every day, and you don't know whether you're doing good or not. So we developed a very unique technology which is called True Wellness Meter. The True Wellness Meter tells you how well are you doing today with respect to your health. It's not like your cholesterol, it's not your hemoglobin level different. It is not from comparing with the generic. It is on your own health. And this is the technology we implemented in a 5-care model. The care can happen in a hospital or a health center. Care can happen in a mobile health facilities. And Nishit was talking about ambulatory cardio care, something like that. And the care is coordinated and managed through a digital nerve center. Doctors are present. Care can at home. All of this managed through a coordinated centralized care by a care team for this 90 days plan. This unique aspect of this model is True Wellness Meter and a personalized care planogram, as I mentioned. It is fully data driven, which is extremely patient centric, so that it is highly scalable. Just set up a context. If in a health center, let's say Dr. Chokshi is able to see about 200 to 250 patients in a month, this model will help Chokshi to see about 2,000 patients. That is the power of this. And it is an economic model. It is not a technology cost model. And this care delivery model for any time, anywhere, with all the different care settings, with team. This is the trick behind it. We generally know care provided between a doctor and a patient, but here there's a patient called a health companion. The health companion associated with the junior doctor and a senior doctor. This is a front-end team. They do everything with the patient what they need. Behind them, there's a specialist group of doctors. There's a nutritionist, physiotherapist, mental health aspect of it. This whole care team, based on the need, they come. Most of it is done through technology. What it requires to roll it out is a proper standardization and training. So there's a technology platform and an AI platform which manages the training. And that is the overall model for the urban. So this is the offering, AI-driven clinical excellence. And it is a digital now center-driven model where every aspect of the patient delivery happens through a centralized, coordinated manner with the proper trained resources. So this can happen anywhere. For an US, now think about it, suddenly, see we have in the United States, 50 states, 50 different health procedures, regulations, all of it. Overnight, we can bring together model and then can comply to every HIPAA, comply to every state regulation. At the same time, you can do it. Yeah, Dr. Amit Chokshi can do a lot of work for the state of Michigan from here, or can do it for different counties within the state of Tennessee. So suddenly the technology elevates you to manage your resources better optimized, and the cost can come down. This is the first time you can see you bring in a technology, you bring in more people, you put in more of effort, but you can bring the cost of delivery. And that's an interesting, unique aspect of this model. So this is some of the acknowledgement we receive from our patients. And it's there for you to read, and pretty much the quality of care is extraordinarily appreciated. Why I'm putting this chart out is because it's a proof that the care is really making sense. The similar approach, we have taken it for the rural part. The rural part is very different. Urban India or any urban city is predominantly chronic disease driven, whereas rural is an access problem. A junior or a doctor who is there in a rural settings, he doesn't have the same amount of access to various medical equipment, medical process, procedures, knowledge. And he cannot administer so many of diseases himself. So making a general practitioner or a family practitioner or internal medicine into a super GP is a very important aspect of technology. And that's what will make you to scale. So the technology which you have developed here is the technology operate in the background and put the physician in it. And can you imagine that a doctor-to-doctor consultation is a very important aspect to treat a patient. That you factor in, today we do it on specialist basis, on a referral basis. But if you factor into the process, in every consultation, another doctor can be brought in, or before consultation you can bring in. That's a kind of a model. And this model we conceived with the primary health center physically available, and a primary health van which is physically available, a digital now center where you have a doctors coordinated anywhere in the world together, and a doctor-to-doctor consultation with an AI-driven model, making a general physician into a super GP. And that's a kind of a care. Then anytime we have a separate care network model to further go in. This model we have conceived it based on our rural experience, and we are in the process of taking it to the rural India soon. So coming into the United States thinking, and we are trying to leverage from the Tata Group our deep experience in this field and the innovative technology method what we have, and trying to see whether we can create an impact in the chronic care management. That's kind of one of my purpose of the visit to the United States, seeing that how we can bring in all our experience and knowledge to various aspects of chronic care management. So I'll quickly stop here. This is our experience on what we have done. Now, the topic of the today is on AI. What is AI? Why everybody is curious about it? Some people are anxious about it. Some people are feeling that like a gold rush. Some people feel this is going to be the future. If you don't do it, you are going to be missed out. And the initial introduction, the same concept was brought in. So there is an amount of kind of excitement, amount of fear, amount of uncertainty, and comparing AI with the nuclear bomb, everything is happening. So I'm just trying to this morning try my best with my experience and knowledge to demystify this. So we need to take a step back before looking at the AI. There is one thing on technology. We saw a big wave of technology change in the 50s with an innovation of transistors, and it started into a mainframe computing, distributed computing, the major impact which is brought in because of internet. And currently, in the current year of 2022, we saw there's a major explosion of AI everywhere. Today, even if you want to talk about if a child is trying to manage his bike and able to change the gear, it says AI driven. So AI becomes everywhere, and anything in technology we say AI. And one thing if you notice, on all this technology explosion, healthcare is one sector, never embraced it first. If you take in the US, when the technology was coming in, which sectors adopt faster? Healthcare is one sector just above public sector. So it is clear that technology is not very important for healthcare. Why so? The reason is very simple. A patient is presenting with symptoms and evidence, and the doctor is fully trained to provide treatment. What is the use of a computer over there? So it's not intuitive. We got to make everybody government has to regulate to put EMR and make the EMR implementation, and everything we need to administer through computers. All of this is done. So never been in the history, whenever the technology happened, the healthcare professionals did not think that is important. Yes, because intuitively, technology is not important. And there is no necessity for the computer. Of course, we have seen a major great impact of technology in diagnosis. We have seen in surgery, in equipment. Companies like GE, Philips, Siemens, they're able to create a huge impact, and we saw. But in a care delivery setting, in a patient interaction setting, there has never been a situation where the technology is important. That is the reason. And second important reason, which is healthcare is one sector where we have a lot of unstructured data. We saw the computerization becoming great and high impact where the data can be organized. If you take financial services, if you take retail, if you take manufacturing, aviation, any sector, the most of the data is highly structured. But the healthcare is one sector where more than 85% of the data are unstructured. So because the nature of the data is unstructured, it is very difficult. Same doctor, same prescription, similar condition, but when they interact with the patient, it will be very different. So that means the data in healthcare is very, very different. So most of the health system which we develop, technology when we develop, it is developed with regulation in the mind and with the payer in mind. So these two reasons, healthcare by itself doesn't require technology that much because it's not intuitive in a care setting. Data is unstructured, and most of it is done from the payer-driven and the regulatory basis. So because of all these reasons, the technology never be important. But for the first time, a technology which is coming into existence, which looks or necessarily it's so interesting that it can really create a huge impact for healthcare. All the healthcare problem of unstructured data problem is gone in AI. All the intrusion of technology making enter to data in the computers is gone in AI. and not to worry about the rules of the regulators and the payers. All of this is already AI can handle it. Suddenly, a new era is happening where AI or this technology or whatever is happening we call AI can solve the bigger problem of healthcare. That is the unique circumstances we have come in. So, one thing is very important, AI is not an IT project. AI is not a technology project. AI is an immersive experience. Assume that if you are going to go to a new country or a new land where you are going to live, most important is you need to understand the culture of that place, you need to know the language of that place and be with it. So AI cannot be given to an IT of an hospital to deal with it. Or AI cannot be, a healthcare company cannot give it to a CIO to handle it. Or AI cannot be done like a technology project. Or AI cannot be done by bringing in some of the top consulting companies to come and advise you how to use AI. In healthcare, it's not going to work because healthcare is very deep already where they are very close to AI. It is a question of switching on a new faculty in your brain, and every doctor, every health professional, every administrator start thinking immersive as an AI, then AI will create impact. So this is the first thing I wanted to present to this morning to you, that most important, don't treat this as an IT project. Don't think that a technology computer programmer is going to come and solve your problem. So with that, I also wanted to get you, because there's so many different companies, so many different technologies, so many billions of dollars are addressed in a venture capitalist and a private equities on an AI technology. Every alternate day, somebody is going to come and see us and say, okay, this is what I'm going to have. So it's going to be extremely confusing. So what I want to do this morning is quickly demystify and give few categories on what's happening in AI in the current world. So I want to divide the AI activity which is happening today into 5 blocks. First, the patient coordination and engagement. There are companies, there are technology which mainly does it. Like if you have seen this chatbot driven communication, there are people behind, there's not really a machine is operating behind, and that personalize and communicate with you, they do the care coordination. So there are companies, they work behind, and it's all done by technology, which is one technology which is more or less mature. And we have seen significant amount of this. The second one which is happening is based on, I just want to simplify, there's something called large language model and generative AI. It's essentially an ability to translate what we have done before in a meaningful way on a particular situation, based on what you are seeking for. So taking this coordination and engagement, the large language model is able to give a management of an individual situation. So imagine what it is. Somebody is calling, or there's a situation is happening on a patient, and the data is collected through a wearable, and an automatic chatbot can get in and give the advice of patient what it can do. And whatever personalization has to happen to the individual patient can happen through this personalized self-management coaching. So this is kind of an AI coaching and AI guiding coordination model. There are few companies are reasonably doing well. Then we can take it up further, which is what I was talking about, the monitoring for the 90 days, 1 year plan. So there's a lot of monitoring, data collection, which is, you have an IoT sensors, which was already there were 20 years before. We were talking about personalized medicine, DNA-based medicine, having patches, wearables. So like a continuous glucose monitor, that block, those things comes into this group, where continuous flow of information comes in, which comes from the sensors, and the ability to process and give you certain assistance. That's the second block of AI. The third block, which is very fast growing, and it has started creating impact already, which is skilling the people, upskilling the people on all the existing resources, so that they can start focusing on few areas and other things technology can do. So the knowledge sharing platform and the ability to train people is becoming fast paced, and which is very important. Again, don't look at like the traditional technology like learning system we had before. This is very different. It is dynamically learns and gives you the knowledge what you want. Like for Dr. Amit, if he's practicing for last 40 years, but in next 4 or 5 months, it can give knowledge what he has never learned before. That is the kind of training capabilities this AI engine is bringing in. And these 3 are all support services. For me, the most important classification is the clinical excellence. I just want to spend few minutes on this. There are few companies trying to do it, and in fact, this is core of our what we have done. Whatever I presented to you in the last hour or so, the core piece is ours, that we have done this clinical excellence space, where you have a kind of an ambient listening, you can recognize the speech, doctor and patient consultation happens, there is no EMR required, it automatically takes the data to the EMR and start acting on it. The licensed nurses can become a health companion to deal with the situation. A lot of knowledge doctors having, which can be given to several other people, so they can do those activities. And more importantly, machine can take over all this clinical excellence. Here, very interesting, this is where the technology of AI today has gone far advanced. And healthcare requires certain amount of deeper work in this. I would say, if you look at next 24 months to 36 months, what's going to happen in healthcare AI field, most of the healthcare institutions will be investing or need to invest here. The rest of the things will follow. The clinical excellence is the area where the AI is going to create an impact. I'll qualify this a little further. As I was explaining why the technology was not adopted in healthcare, the reason is technology never could be deep clinical. So no medical professional will appreciate a technology can help them in decision making or care provisioning or treatment protocol or therapeutic situation. Here, there are technology which has got that capabilities, and the only way you can implement this if you are already deep clinical, deep digital. Unless if you are deep in clinical and deep digital, the AI cannot save. So now that's a first step. So this clinical excellence is a very important model where I will show you one video to explain that a little deeper, easier. Then the fifth area is the diagnostics area, which is about 10, 12 years of technology, which is called machine learning, and which is based on certain sensors, certain predictions. The machine starts learning the way you operate. And so this is like an image, let's say CT scans and MRIs. All those images, as millions of images are available in your storage. You superimpose on a AI technology so that the new patient comes in, the whole radiology can be done. The teleradiology model, all of this is part of this. This is a machine learning technique. Above this, you have robotics. There are a few other techniques. But from the healthcare perspective, when you look at it, you can classify anything which is happening in AI into 5 buckets. And a very important aspect of way to understand AI, that's the way I understand. So, in summary, AI is part of the core. It's not an enabler. And I quickly wanted to give an example so that we can understand in a practical real-life scenario. See, we know we use EMR and all the time we enter data in an EMR in a consultation setting. No need for computers. AI is a technology where you can avoid computers. So computers goes out of the window. Instead, AI comes to a place for an. So imagine a consultation setting where AI is there as an invisible presence over there. In this genie, the AI already senses the doctor is starting a consultation, so it takes a permission from the doctor to start the consultation. And the consultation is going on. The AI is listening as an ambient listener. It keeps listening what it is. Then it starts its own notes. everything is translated, transcribed, and all the medical jargons are picked up, then all the different interaction has been taken in automatically. Not only that, the EMR is automatically populated. No need to enter data anymore. Not only it stops there, it can generate notes, which is the most time-consuming thing, because most of we don't have time to do it, and we don't do it. And it can prepare the note, whatever the standard you want. This note looks in a SOAP note standard. In addition to that, you can ask question to AI, but it can go one step further. Because of your continuous practice, because of the AI ability to learn from you, it can create its own question and start giving the answer, because as what knows about your practice and what you do, it can start preparing notes and questions for you so that you know exactly what other things which you don't know, the system can give you. So, in summary, what I feel is AI is ready, and it will continue to evolve. The question is the healthcare is ready? If you are ready, then what we need to do, or if you are not ready, then how we can get ready. So this, I will stop here, and we can open up for our discussions on this topic. Yes, Nishit.
Thank you very much. I think it was a succinct presentation and easy for us doctors to understand. I think you were talking about technology, doctors are frightened or are frightened about technology because during school, college training, we never learned technology, but when we deal with technology and we kind of don't accept it as quickly or adopt it as quickly as other specialties would do, non-medical people. Having said that, this platform really makes it easier in the way you have described it. It's more easier to be able to adopt this kind of platform in the overall healthcare system. The one thing that I really see advantageous is the payers. Whenever we are trying to do any testing procedures, etc., we get clearance from them. And 8 times out of 10, nowadays particularly, they refuse it, they turn it down, because some appropriate wordings are not there, in fact appropriate history, etc. And at the other end, we have a non-medical person, or a medical person, but maybe a nurse, who may not have all the knowledge, and they promptly turn it down. Then we have to do peer-to-peer. The peer-to-peer, the primary care physician or somebody else, and there's a cardiac issue, and then we fight, 30, 40 minutes go by, and then I tell them I'm going to put your name in the chart. If something happens, but I want to do a cardiac cath on the patient or a vascular procedure on the patient, and they will not allow you. And so I think this technology, I think even the peers, their systems will get more streamlined, and it will help us and help our patients. And one other observation, as you had mentioned, is in India, big line, 2, 3, 4 days to wait in the OPD. It's not much different here either. If you have to see a specialist, it's 2 to 3 months to see a specialist. So recently when my daughter's father-in-law needed a hematology consult in Atlanta. And a big city, many, many doctors, multiple huge systems. The first appointment was 3.5 months later. I had to make some phone calls with my friends and got it earlier. But so the problem is here too. And then what happens, chronic disease becomes acute, and they flood the emergency room. And now the wait in the emergency room is 6-8 hours. So that becomes actually a primary care center, because neither the primary care doctor has the time to see the patient, nor does the specialist have the time to see the patient. So I think with this platform, you said that if you're seeing 20 patients, you see 200 patients, so to speak. So I think we have to adopt this platform for our own good, for our own sanity, and above all, patients' good outcomes. So I think this is here to stay, and if you don't adopt it, it will be left with us.
Thank you.
doctor if that were a nurse practitioner. And if AI is listening in, they give the same advice. Is there a chance that could replace the doctor?
See, it's a very important question, and the way it is evolving is you have to think like this. I feel the depth of medical knowledge, the clinical reasons, what a doctor is possessing is never going to be replaced so easily till it becomes so proven. In healthcare, one of the biggest challenge of healthcare, implementing AI, the specific question which you are asking is, it cannot be 99.99% correct. Even a 0.01% you are wrong, and then you are impacting the patient's health. So you cannot make a wrong decision through AI. So it's an evolution, and still I feel for a few years it will be with, there's a technology which is coming in AI called checker and maker and checkers. There are a lot of checks will happen through the technology by AI. And I don't think for next few years it's going to replace a doctor, but it can bring in different type of a medical professional who become a validator so that it doesn't break. So if the AI in a retail industry or a financial services industry is very different, where it can be 99% accurate, it can make it efficient. But here, 0.01% not working, it cannot work. So in healthcare, especially on the clinical excellence stage, it's an evolution. It's not going to replace doctors so soon, so you don't need to, it will take time. That's the way I see it, but there will be a lot of new things will come to this, but it will make a doctor efficient. A doctor is seeing 20 patients a day, he will start seeing 200 patients a day because of this.
So I'll answer that a little bit too, because I think most physicians, they understand, as I was saying in my opening remarks, medical knowledge has just gotten so large, we need help. But I learned in high school when you're first taking computer classes that junk in equals junk out. So the key and the challenges to me have been who enters the data, and how do we know that the data that's getting in is not junk, that it's the important part of the conversations. And I think that what I'm seeing, the leaps in AI finally starting to address the real problem is who's going to enter the data and making sure that the data is entered in a way that it can then give you not junk out, but meaningful things. Because looking at my career here at Murray Regional for 22 years, that the burden of entering the data got shifted to the doctors. And the doctors then were sitting here typing and trying to enter all of this important information, and until AI can address and fix that problem, we're going to constantly be at a challenge. So very glad to see, and we're trialing some things like that already, where it's listening to the conversations and it's putting it in. But to your point about doctors, somebody still has to review that data. It's not so good right now that AI is getting it in just right. So you want to make sure you get the right data, but you're not getting the right answer. And knowing that answer is coming out correctly is going to still fall on somebody who has a medical education, who knows what's good and what's not. So,
Fantastic.
Very interesting talk. I appreciate you coming. Appreciate you being on the forefront of this. Excited about what the future holds for my sons in medicine and for all of us, because we're not going to be able to address the real problems with healthcare by ourselves in the old-fashioned models. It will not happen.
Fantastic. I totally agree with you. Your assessment is absolutely the way I think. Yes, Nishit.
So you have digitized a whole bunch of thousands of patients in India, digital passport, so to speak. How difficult was that, or what was involved in digitizing all these patients? example, if a patient comes to my office and his digital footprint is already in the space, then it becomes that input that we have to do becomes easier. So how difficult was it for you to do that?
It's a very important question, and the answer is you don't need to. First of all, we didn't start there because that was the biggest problem. So I'll share my experience on this. See, when I studied that health exchanges was created in the US and Australia and some other countries, it took about 7-8 years for them to get the first health exchange work. If you really look at it, the data so they all waited for the data to come and data to come in a correct manner to create proper interoperability of data. So we realize if you take that method, not only you're going to be very late and you're not going to be relevant. So we said we'll not wait for data. We start now, from now on we'll be okay. Forget about the past, let's get whatever so the 2 principles, we start now. So don't worry, wait for the data to come. Second thing, we need to have this technology, that's one of our unique technique. Whatever the data, however the data, we accept. If you try to expect the data to come the way you want, you will never get it. So now, the beauty, this is our experience, which is about 5-6 years before we started. The beauty of today's AI data collecting technology, which has the ability of cognitive skills. Like the way human looks at the data and able to segregate and bring the data the way you want, AI can do today. So the data collection and data quality, the input data which I was talking about, and has become more easier and accessible and effective in the new technologies which has come on AI. That's where the cognitive ability of AI, of generative AI and large language model comes to a major part of it. So to answer your question, Nishit, going forward, you don't need to do that. The AI has the ability to curate the data and bring it in. So the interoperability more or less 90% available the day one. Then you might need to do some 10% of cleaning up and making the systems ready. So that is a big difference compared to what is 15 years before and today. I've gone through this part of our technology services business, trying to bring in multiple hospitals together and bringing all the exchanges together. It's a very time-consuming, tough projects. Most of the projects fail. Yeah.
Could I, so this is pretty neat. There's one thing that I wanted clarification of, which is LLMs are really good, really well trained already to handle information like you said earlier, if it's good. And in your case, you're using a base LLM, you're using several mics in the room, you're recording, like literally, by listening to the conversation word for word, transcribing to the mics. Those words are then being sent to an LLM, probably one of the big LLMs by the big tech companies. Those LLMs are then tasked to parse those notes and fill in automatically your SOAP standard. So that's the whole AI. The only flaw that is actually not, in my opinion, it's not really a flaw, something to consider potentially to really factor in, especially if you expand to international audiences where there's different accents, there's different language and things like that, is that the recording devices themselves, and if anyone's ever tried to send like a voice note, don't do a perfect job of capturing the full conversation. So in your like AI system, you would still need a doctor after the recording's done, after it's sent to the LLM, after it's parsed into the SOAP notes, to essentially review the SOAP notes for accuracy, which at that point becomes complicated because then you're asking the doctor to remember everything anyway, and to remember everything anyway, they would have to take notes while they're talking to the patient. So how have you made sure to ensure that the SOAP notes that are generated are indeed accurate, given that there are likely inaccuracies in the recording itself, not necessarily the LLM parsing?
I understood. understood the question. So there are two parts to it. First of all, there's not only in our model the general LLMs are not going to work. It's not going to cut the cake for healthcare. And there's first and foremost in our chronic care management. You've just taken one example of AI. I just want to demonstrate for people. That's what I showed you, SOAP notes. So first I will respond to you on the first part. The 30,000 patients which we took and created the care planogram, which is our data. And that is the protocol and care pathways which we have developed for various chronic diseases. The 5 million patients whom we have dealt with, where what we have learned about various diseases and everything, it's our data. It's not available in other LLMs. So you have your own LLM by diseases, by protocols, with hundreds of physicians' experience is already decoded. So that's the initial experience part which I presented. All those experience parts is translated over here. So it just doesn't stop with an LLM what that things gives in. The second part which you mentioned, by the way, he is a PhD in AI and he run an AI business, so a little more technical details. And it doesn't stop with the prompt engineering and promote further more fine tuning it. So that's the initial aspect of getting things right. Then your own LLM model or a deeper knowledge what we have and a little bit of machine learning together gives you a different answers and different perspective on it. Then coming into the SOAP notes example which you talk about. So when I started, you are absolutely right. It was about, we are 62% accurate. So that means somebody has to manually do the maker and checker and do this. Today, in terms of SOAP notes, we have reached about 98.4% accurate. And as we move along, this is becoming better and better. And that's where you bring in efficiency. And of course, we have done about 2,500 patients on the maker and checker model. And significantly, that becomes a machine learning technique to fine tune it. So as you rightly say, as his question, there's an element of process involved, but as you move along in this direction, depending upon the context, if you take a thyroid as a disease, we are able to see a phenomenal accuracy. If you look, because it's a medical field, it's a humongous language model. The next complicated point which you brought about, just ambient listening is the one aspect of the solution. And let's take a little further on what is the purpose you are using the ambient listening. Ambient listening, let us say if I'm going to use it for the structured data purpose, which is the data in the EMR, it is much easier because EMR already has a checks and balance so that you're not going to get a junk into there. So ambient listening to EMR is an easy project. Ambient listening to create a clinical care pathway for a patient requires certain amount of supervision. So the way to answer it, it is evolving and you take lead and you'll fall in line. Right. The last part of the accent piece of it, we started with English and just for the audience, we have more languages in India, regional languages. We are pretty successful as of now, English plus about 3 languages. And it is pretty fast. And the way AI picks up language is much faster than what we think of. And thanks to companies like Google, Microsoft, and all of them, they have invested billions and billions of dollars on this. And India being a country with about 1.4 billion people, and a lot of investments happening in Indian languages and various other languages to happen. So I don't worry about language and accent as a major issue. It's a question of implementation issue. And I'm not saying everything is available for tomorrow morning, but the objective of this session and this thing is how do we prepare ourselves? How do we demystify AI rather than thinking that somebody else is going to solve the problem?
Dr. K, so would you consider AI a bridge to risk? Right? A lot of what the burden is the payers are wanting to see the data, right? It's unstructured, but we're not comfortable, we're in a fee-for-service environment. 90% of what we do in the world is fee-for-service. 10% people live off of risk-based contracts. do you see that being a bridge for us to get more comfortable? Because we're gonna understand the data better, so we can enter in risk, because the reason to enter in risk is there's some better compensation for the burden we're putting on our physicians in the care they're providing.
Fantastic. It's an amazing question where AI is going to play a pivotal role in the future. So there are two parts I want to answer. First thing is, culturally, or how do you need to approach it, AI as an hospital or a physician? AI is not a project, as I mentioned, somebody else is going to do for you to make technology work for you. It is you are going to become part of this. That's the only way AI is, because AI is not something very different where you are not used to it. It is as simple as how you learn driving. It is as simple as how you can implement. You just do your normal work. But along with this technology, then automatically you'll start picking. If, for example, I will encourage, don't try to practice generative AI for the purpose of medical practice. Probably start helping your children or grandchildren in writing essays through the LLM models. Start writing for your natural life, for something you want to know, you start using generative model to get used to it. Once you start getting used to AI the way you think, then it becomes much easier. The way about 15, 20 years before mobile phone was a new thing for us, and especially smartphone, where we initially had a lot of resistance. But now it's part of our life. And it is not because of the mobile technology. It is up to the immersive nature of this technology took your life. The way the Google Maps, when it started in late 90s, we were hesitant, then still we were printing directions from the printer and taking while driving. But nobody does that. So my request to approach this is, first you start becoming part of the AI world. Then you will know exactly in your day-to-day job how it is going to happen. And this is the first part I want to say. AI is not an IT project. AI is not a technology somebody is going to do for you. There is no big 5 consulting firm coming and going to teach you how you need to use AI. All of this will fail, in my opinion. The second part of it, this is a big old problem in the US for a very long time. The claims processing, submission of claims, dot the I and cross the T is been a situation, and for a reason it has been a situation their way. And I feel AI is one which is going to help the payers the most. And they're going to find mechanism in various, what they could not do before. All these checks and balances systems payers brought in because of a lot of lacunae in provisioning care. Now, when AI is going to change their world, automatically it's going to become simpler. And so a lot of this work is going to shift. And if it is going to, a lot of things is going to shift right, some of them are going to shift left, but I don't think it is going to take a lot of job out of this game. And it is going to make our life more efficient and interesting. I don't know whether I answered your question. Yeah. So I think it's okay to start. Yeah.
One quick, as a non-medical person, as I listen, the understanding I have of AI from you today is that it's almost this spiritual friend that gets to know us or gets to know our field, helps us do our job. And it's whereas historically maybe I've looked at it as, you know, I'm using somebody else's information. Well, it's going to use others' information, but as I understand it, it's going to use me too.
Yeah, it's a very beautiful way of putting it. So there are concepts called assisted AI, co-pilot. There are a lot of different terminology they use for the point, but you kind of you can think like this analogy. There's a companion who has got a lot of ability to give you support the way you want.
Like a mom or dad who's always right.
Yeah. That's a good way of ending. And if with your permission, I'll close it. Thank you. Thanks for having me here.